title of this talk is High-Risk OB Anesthesia Clinics, and it's not quite as jazzy a title as the title I had on Friday, where we talked about tranexamic acid and fibrinogen concentrate. Should we give or should we not give? So I thought I'd give this title a bit more of a Shakespearean theme, High-Risk OB Anesthesia Clinics to have or not to have. All right, so for this talk, there's no disclosures that I have to declare. So when I was preparing this talk, I was wondering what questions do I think the audience might be interested in with regard to OB anesthesia high-risk clinics. So I thought to myself, well, let's think about what we mean by a high-risk patient to start with. And once we've figured out what we think we mean by that, where should we evaluate these patients? Should it be in a clinic or should it be somewhere else, be it on labor and delivery or a different venue? If we're going to think about a high-risk OB anesthesia clinic, what is it and where should it be? And last but not least, what are the pros and also what are the cons in establishing such a clinic? So we'll try and do our best to address some of these questions. So before we do, let's just imagine a hypothetical scenario. Let's say that you're the lone wolf anesthesia provider on labor and delivery, and you've been flat out doing epidurals and C-sections all night, and it's now 3 a.m. on Saturday. It's always 3 a.m. on Saturday. Amazing, isn't it? So you get a call from one of the nurses in the room. She tells you that there's a lady who's interested in pain relief. It's Mrs. Smith. She's 42. She's a multip. Okay. And you go in the room and you do an eyeball assessment, and according to the record as well, her BMI is 40, which by California standards is a little high. Okay, all right. So you find out she's in active labor and she's requesting an epidural. Fair enough. On further questioning, she tells you that for her last delivery, she had a cesarean section. It was unplanned. She had a general anesthetic. She doesn't remember why. It was in an outside hospital, so there's no way you can access the notes or the medical records at this time of day. Okay, that's quite interesting. So not surprisingly, she's here, she's in labor. She's already agreed with her OB that she wants to have a trial of labor after prior cesarean section. So you weren't involved in that loop until now. So overall, there's a few little red flags, but you're probably not too worried at this stage. But on further questioning, she tells you that she has a bleeding disorder. She doesn't know what it is. She thinks it's called von something, at which point you start to sweat a bit. So you ask her if anyone else in the family has a similar problem. She goes, oh yeah, my mother bled to death about 40 years ago during GI surgery. At which point you start to wonder to yourself, okay, well maybe I need to talk to her about preparing for blood loss and transfusion. And you mention the transfusion word. She looks back at you aghast, saying, there's no way I can have a transfusion. I'm a Jehovah's Witness. Don't you wish Rachel Kakmar was in the room? So that's a problem. And then just as you're trying to formulate a plan and talk to her about what that plan might be, your pager goes off, and it's the front desk, and they tell you that 2 multips have just arrived. They're both in active labor, they're both in a lot of pain, and they're both asking for an epidural. So this is not an ideal situation. And not surprisingly, your reaction might be something like this. So wouldn't it be easier and perhaps better if perhaps such a lady may have been seen earlier during the antenatal period? Do we think that would be a good idea? And hopefully, I would hope the answer is yes. So it's nice for us to consider how we best triage these patients. And when I thought about this, I thought to myself, well, what do we mean by triage? And I actually looked it up in the dictionary. And what it means is it's the assignment of urgency or degrees of urgency to wounds or illnesses to decide the order of treatment of a large number of patients or casualties. So this really applies to us as OB anesthesia providers when we're trying to think about whether patients are low, medium, or high risk, and depending upon how we classify patients, how we're going to evaluate them before they enter labor or before they deliver. So obviously much also depends upon volume. And that much depends on that, depending upon where you work. And so there are scenarios, just like we heard, where you may have ladies arriving at the same time, you're not sure about their degree of risk, and they all want their epidural. So we need to do our best to triage in the heat of the moment. But there's lots of demands that we face, certainly in this day and age. And it's really hard to get good quality data to know whether the volume has gone up and the demands on our service has gone up. But what do we know? Well, there's some interesting data that was published by the CDC, which looked at rates of spinal and labor epidural use for women that had singleton vaginal deliveries back in 2008. And if you look at the bar to the furthest, on the furthest left-hand side of the graph, you can see here that nearly 2/3 of women back in 2008 that had singleton vaginal deliveries received either an epidural or a spinal-based method for pain relief in labor. Now, what we don't know is who gets pain relief in labor via a neuraxial route if they have, say, a twin pregnancy and they're planning a vaginal delivery, or perhaps more importantly, women who undergo a trial of labor who end up requiring intrapartum C-section. Now, the other issue for us is C-section itself. We've seen, in general, an increase in the rates of C-section over time, and back in 2012, the rates were just under 33%. We've seen a general plateau, and they're just coasting above 32% right now. So nearly 1 in 3 women has a C-section, and not surprisingly for us as anesthesia providers, we need to be there to provide them, hopefully, with good quality anesthesia for that delivery. So with that in mind, when we're dealing with someone who we think is high risk, are there any benefits when we think about seeing them in the antenatal period? And hopefully the answer is yes. The best thing about this scenario is you've got the luxury of time to perform a detailed evaluation and formulate an anesthetic plan. If you think there's been inadequate workup, then again you have additional time to order tests and also to seek out expert opinion from other internists or other surgeons to help formulate what you think the best plan might be, which may not necessarily be for anesthesia, but in terms of the multidisciplinary plan. And I totally agree with Regina. It's very important for us to liaise very closely with OB so that they know what we would like to do and we know what they want to do. And then maintain ongoing communication because, as we know, Mother Nature has a habit of wrecking best plans. So if you formulated a plan for a high-risk patient who's planning vaginal delivery, and then 2 weeks before her due date, her baby flips, and now her baby's breech, and the OB wants to do a C-section, you then have to modify your plan if you've only had a prior discussion about pain relief in labor. So perhaps the best place to do all this and consolidate all of the plans and the scheduling and the arrangements for evaluation is the OB anesthesia clinic. So have we seen an increase overall in the volume or the acuity of high-risk patients to justify having a high-risk clinic? And this is a really difficult, if not impossible, question to answer. What we do know, though, is that we have seen an increase in rates of maternal death in the US. So this is data from the CDC looking at the pregnancy-related mortality ratio. So this is the number of deaths that occur per 100,000 live births. And what we're seeing here back in the late 80s was a rate that was around 7.2. And when you look over to the right side of the graph, you can see here the rate in 2012 is just under 16. So the rate has more than doubled during this time period. It's pretty astonishing, bearing in mind, obviously, that we've seen improvements in medical and obstetrical practice. One wonders whether we're seeing a greater proportion of women who have high-risk pregnancies who may be contributing towards this. What are the causes of death that women are experiencing in the US? So this is a recent publication published by the CDC in the Green Journal. And what we're seeing is a change in terms of the etiologies of causes of death in the US. So back in the late 80s, we saw more traditional causes of death being the most prevalent, so hemorrhage, hypertensive disease, and preeclampsia. Now what's happening is the proportion of deaths that are occurring from those conditions is going down, and we're seeing a greater proportion of women who are dying from cardiovascular disease, cardiomyopathy, and non-cardiovascular medical diseases. So these are medical diseases that hopefully the obstetricians and we are knowing about well in advance of the due date that we can potentially have an influence on and mitigate if we're seeing these patients early on. Now, are there any contributory factors that we as physicians are involved with in terms of causes of death? So this is a really interesting report that came out from the CMQCC. This is the California Maternal Quality Care Collaborative, and they published data looking at causes of death in California between 2002 and 2005. And then they looked to see whether there was any physician-level factors that may have contributed towards the causes of death, depending upon what the cause of death was. And you can see here that there were a number of different contributory factors that they identified, including delayed response, ineffective care, misdiagnosis, lack of continuity of care, and failure to consult. And again, some of these may potentially be mitigated if anesthesia had the ability to see these patients early. Now, in the report, there's no information about that, but one wonders whether perhaps we can get involved in reducing some of these deaths if we're evaluating these patients before they arrive on the labour and delivery unit. So are there any guidelines or recommendations from national societies, anesthesia societies, about how we should evaluate high-risk patients? And the answer is yes. This is the most recent report, which I encourage you all to look at. It was published by the ASA and SOAP about practice guidelines for OB anesthesia that came out in anesthesiology a little earlier on this year. And what they say in the report is that we should recognize significant risk factors, and that should encourage consultation between us and the OB anesthesia provider. Furthermore, as we heard earlier on, a communication system is really, really important for not just establishing early communication, but ongoing communication between all members of the multidisciplinary team. So it's not just OB and anesthesia, but other surgical and medical providers as well, if we're trying to involve them in a multidisciplinary plan. Now, this has been emphasized in other reports from outside the US as well, including the confidential inquiries into maternal deaths in the UK. This is just one of the reports that came out in 2011, looking at deaths between 06 and 08 in the UK. And you can see substandard care contributing towards women who died from direct deaths, so deaths directly responsible from pregnancy, or deaths that occurred in medical conditions that were exacerbated by the pregnant state. So one of the recommendations in this report was that they should involve an anaesthetist early. You know, it's the UK, so they love extra vowels, that's why I bolded the A, for women who have severe acute disease. But in my opinion, I think we should be involved in patients that have severe illness, be it acute, subacute, or chronic. And again, that maybe emphasizes the importance of early evaluation. So how are we seeing these patients? How are they referred? And obviously, we're mainly relying upon the OB or the OB provider to tell us about these patients. So what are the mechanisms by which they're sending the patients to us? And I've really tried to classify these into a number of different groups. So we're going from worst case scenario to best case scenario. The worst case scenario is you don't get any information from the OB at all. So the first time you see him is when they're in labor or the day of or the day before a C-section. So it's probably not the best timing that we're seeing these patients in. Slightly better is perhaps the OB sending the patient to the labor and delivery unit, you not hearing about them, and you're trying to squeeze in an evaluation whilst dealing with the demands of the service. Slight improvement on that is you're getting a call from OB, so you're hearing about it. There's no venue for you to see the patient, so you're having to see them on labor and delivery, but perhaps there's an improvement in terms of how the patients are being scheduled in advance. And then the better options are if you have a clinic, you may be able to see them in the preoperative clinic, or in an ideal world, an OB anesthesia clinic. So that way you've got the luxury of time, space, you're not distracted with anything else that you're dealing with if you're covering labor and delivery or the OR at the same time. So how common are these clinics? And unfortunately, there isn't really a lot of data on this. There's some information that came out from the UK back in 2005 by Ray and colleagues, and they surveyed just under 100 different UK lead anesthesiologists to determine whether they had a clinic in their hospital. And what we're seeing here is that not many clinics overall did, but there's a suggestion that hospitals that have higher obstetrical volume may be more likely to have an OB anesthesia clinic. In an older study done by Hamer and colleagues, they surveyed 21 lead international anesthesiologists. So this is a global survey, and amongst the questions that they asked them if they had a high-risk clinic. Less than a quarter of them, at least at that point in time, did. But remember, the survey that came out at the time was quite old. Mohammed Terrain and I, Mohammed comes from the University of Virginia, we were very interested in this, and we actually surveyed directors of, OB anesthesia directors of academic tertiary centers in the US very recently. And amongst the people that responded, we asked them about whether they had a clinic, and less than 40% of respondents said they had a clinic. But amongst all responders, whether they said they had a clinic or not, one of the things that really surprised us was that 20% of high-risk patients amongst the responses that we got were still saying that they were being evaluated during labor or somewhere close to the time of delivery, with only 10% of the respondents saying that obstetricians always referred high-risk patients to them, be it in the form of a clinic or otherwise. So this is something that probably needs to improve. And obviously, we don't know how to best improve how these patients should be referred to us from OB. So what type of patients should we see in a clinic, or should we hear about even early, irrespective of whether you have a clinic or not? And again, the data on this is a little sparse and spotty, and the data that we do have generally comes from single centers. So this is an analysis we did way back in 2005, looking at the type of patients that we see at Stanford after implementing the clinic over a course of a 9-month period. And as you can see, the number of etiologies for the referrals is very varied. A lot of them are obstetric, indications for referral. The proportion of women that were obese was pretty high. But I think the most important thing to note here is that over 40% of the referrals had multiple reasons for seeing us. There wasn't just one condition, they had 2 or more conditions that warranted referral, and nearly a third of these patients required follow-up. So they weren't able to get optimized just during the course of the evaluation. We needed to see them again to make sure that additional workup or a change in their status had been implemented before they came back to the labor and delivery unit for delivery. Mohammed Terrain at UVA did a similar type of analysis more recently, looking at the type of patients that were seen in his high-risk clinic. This is in 2013. And again, obesity seems to be a pretty common reason why patients are seen in the clinic, but there's a multitude of different medical disease processes that they're also seeing at the UVA. So there's some similarities here between what we saw at Stanford and what Mohammed is seeing at the UVA. So you're probably wondering, all right, what type of conditions are you guys seeing at Stanford? And that's a slightly more difficult question to answer. So what I did is I looked back at my inbox the other day, because what we have, the fellows that run the clinics, they're awesome, and they send us secure emails, so they want opinions from us about what we think we should recommend that they tell the patients in terms of their management. So I've listed a number of different conditions that the fellows have seen in the clinic over the last 4 months or so. And some of them are pretty juicy. We've got patients here that have had adult cardiac surgery, corrective cardiac surgery, presumably when they were much younger, conduction syndromes, and then amongst the non-cardiovascular syndromes, there's a whole host of different rare or significant issues. The one that I found most interesting was the woman that had a spinal cord injury and prior craniotomy for a prior astrocytoma. I think I would have PTSD actually as well if I did all that. So as you can see, it's very heterogeneous in terms of the number of conditions that we see, certainly at Stanford, and I would presume that that may well be the case in other centers as well. So we try to encourage the OBs to refer as many of these relevant cases as we can. Now the difficulty is, what criteria should you lay down to OB? If you make it too stringent, you may miss out on high-risk cases that you need to see. If you make it really broad, then you may see more low-risk patients, even though you're seeing more high-risk. So it's hard to strike that balance, I think. So what I've done here is emphasize with bold the conditions, and they're quite broad, that we ask the OBs to send us. So we're interested in any patients that have significant maternal cardiac disease, if they've got hematological disorders or they're on anticoagulants, if they've got significant spinal deformities, if they've had problems with anesthesia, be it from non-obstetric surgery, or more commonly if they have bad experiences from having an epidural or from a block for C-section. If they've got other relevant medical disorders, and we've made it very broad, and if they've had any other significant concerns about receiving anesthesia. I think this is quite important because a lot of patients that we deal with may be really anxious about receiving an epidural, be it from a prior experience or from what they've heard from their friends. And I think it's nice for us to see some of these patients if they've got a lot of anxiety, so we can spend the time in trying to allay their fears, which is much easier to do in the cold light of day in a clinic than perhaps it is on labor and delivery, where their anxiety levels may actually be a lot higher. So how do you implement a clinic if you're thinking about doing it? And this is really a little challenging, and all I can give you is just advice from my personal standpoint. So much really depends upon the characteristics of the population that your hospital serves. So you want to capture relevant conditions that are relevant to your hospital, and as best you can, try and avoid low-risk referrals, which I know is easier said than done. I think one of the key aspects here is make sure that you have a robust system that's standardized that OB can refer the patients to you. So you can be done over the phone. You saw on the flyer for Stanford, they have direct phone access to the scheduler in the clinic, or they can call the fellows to help organize the referral. But with the advent of the EMR, and I know they do this at the UVA, they can potentially schedule this through Epic or an equivalent electronic medical record system. But it needs to be standardized to make sure that all the OBs are using a similar process. Where's the best location for this? Well, ours is embedded in the OB antenatal clinic. So the Stanford MFMs, if they're seeing a patient in their clinic, then they can see us at the same time on the same day. So it doesn't involve a repeat visit by the patient, especially if they live a long, long way away from Stanford, which can be very problematic if they're just coming in to see us and squeezing us on a separate day from their OB visits as well. But if you don't have a designated space, you can potentially do it in a pre-op clinic, or maybe there's a designated space that you can create on your labor and delivery unit, or maybe even somewhere in your anesthesia department. So what are the pros and what are the cons of setting up an OB anesthesia clinic? Well, the nice thing is it formalizes the whole referral process for OB. They know where to send them, how to send them, and it makes it a much easier process for them. We have a hub, so it makes it easier for us to figure out where the fellows are going to be on a specific time and day in the week. And certainly in this era of the peri-operative home and the medical home, perhaps if we develop an obstetrical home, then we can embed a high-risk clinic as part of that model. We personally feel that it makes the working relationships we have with OB much closer, and certainly we're establishing much closer relationships with medicine and surgical colleagues as well. And the nice thing about the clinic is that you can bill for your time. You may not have the ability to do that quite so easily if you're seeing these patients ad hoc on the labour and delivery unit. But at the same time, there are some disadvantages potentially. It does take a lot of resources to help set this up. So you do need to find a venue, you need to find staff that are protected from whatever demands that they have on their service, and you need to allow them time to see these patients. So for us, the fellows see them, they're protected from their other clinical responsibilities on L&D. They have a specific time to see these patients, which is on a Wednesday afternoon, which goes from 1 till maybe 4 or 5 o'clock in the afternoon. So they know what they're doing every Wednesday afternoon, every week. If your high-risk volume is low, it makes it difficult to determine whether it's a good idea to establish the clinic. And even if you do want to do it and there's lots of support, it does take a village. So you have to get support not just from your anesthesia colleagues and your OB colleagues, but from the administrators as well. And there's cost and financial support just to set these things up. But one hopes that after they've set up, that patients are happy and maybe improvements can be seen in terms of outcomes. But that's a little difficult to do because it's very hard to determine if outcomes are improved in hospitals with a clinic versus without a clinic. The other concern that I have about this is, and I guess this applies to any evaluation, be it in a clinic or not, is do patients have a better understanding, do they have a better understanding about the high-risk nature of their condition by seeing an anesthesiologist versus not seeing us? And I guess much of this really comes down to what communication we have with these patients when we're seeing them. And the reason why I say this is that there's a really interesting paper that came out in IJOA a couple of years ago where they examined patients' perceptions and information and knowledge about having been seen in a clinic if they were obese, and obesity was the main reason why they were being referred. So this is a single centre study in Australia. And one of the questions they asked patients was, compared to other pregnant women, do you think your health puts you at greater risk during the course of pregnancy? So the white bars are the questions that were asked before they got seen in the clinic, and the black bar, they asked the same question after they were seen in their high-risk clinic. And you can see here that there's a fair number of patients who are either unsure or disagree that their health puts them at greater risk, and there's a greater number that felt that their health didn't put them at risk or they weren't sure after they were seen. So we wonder, what are they saying to these patients in clinic that made them shift towards this statement that they think their health is not an issue in terms of their pregnancy? And they actually have some comments in the article suggesting that some of the providers were a little rude and insensitive about their habitus that made them potentially change their mind about what their BMI was doing in terms of their health status. So I think we need to be a little more sensitive here, and I totally agree with Regina that perhaps we need to better educate ourselves about the best way to talk to these patients. So obviously we need to move with the times. So the times are definitely changing. We're moving from this fee-for-service traditional model to a value-based, quality-based payment system. And there's definitely changes that we're seeing, certainly in terms of how we're going to be remunerated, be it in the form of accountable care organizations, medical, surgical, or even obstetrical home, and maybe in terms of bundled payments where the payment's going to be made as part of a big bundle, and a lot of it will be depending upon whether we're doing good things from an anesthetic practice, and also importantly whether patients are happy. So how can we make them happy? Well, maybe we can do it in the form of an OB anesthesia clinic, which is very patient-centric, but obviously we need to be very careful about how we're conveying information about their high-risk condition when we're giving them information about improvements to their anesthetic plan. So to conclude, we're certainly seeing increases in the rates of obstetric morbidity and death in the US. We don't know whether there's a greater number of high-risk patients that may be contributing to this. I guess the suspicion is they probably are. From a practical standpoint, it certainly makes sense for us to see these patients early, and obviously we need to liaise closely with OB so they have a good idea about how they can classify these patients how they can refer them to us, and then how we can best evaluate them, be it in a clinic or an alternative venue. There's definite advantages with a high-risk clinic, but there's certainly some cons, and much really depends upon how many of these patients you're seeing and what your hospital is like overall in terms of its characteristics. But as you can see by the picture, if there's a will, there's certainly a way. So I'd like to thank you all for your time, and I hope you saw the Bay Bridge at night. It really is pretty. And if you have any questions, feel free to email me, tweet me, or post on the OB Anesthesia Facebook page.